Good morning and good afternoon, everyone. Welcome to today's webinar, Driving Mips Success with Data and Technology, Perspectives from Two Thought Leaders. I'm Nathan Brown, Director of Marketing for SpectraMedics. I'm going to be your host today. A few housekeeping items before we get started. You can ask questions by entering your question in the control panel, in the question part of the control panel, in the bottom right. Anytime during the webinar. We'll be answering questions at the end. We'll be sending out an ebook of the webinar after the webinar. And we're going to be conducting two polls during the webinar. So if you could take a minute to answer, we would appreciate it. So our panelists today are Mr. Sri Barajwa. He's Director of Information Services and Chief Information Security Officer for UC Irvine Health, and Dr. Raj Lakhanpal. Dr. Lakhanpal is the CEO of SpectraMedics, a member of the National HIMSS Clinical Intelligence Committee, and he's also on the governance board of MITA. Our agenda today, introductions, followed by a brief section on the importance of MACRA. And then we're going to be doing a section on MACRA as a stepping stone to comprehensive value-based care, data and technology challenges associated with MACRA, and finally, solutions. And this webinar, we want to give a big thank you to the Southern California HIMSS. They're sponsoring this webinar for us today. They have 2,600 members, and their membership spans across Los Angeles, Orange, San Diego, Santa Barbara, Imperial, Kern, Riverside, San Bernardino, and Ventura counties in California. And if you have any questions about membership with Southern California HIMSS, you can contact Karen Kennedy. Her email is on the screen here, or Jerry Pavia. So without further ado, I'm going to hand the webinar over to Dr. Lakhanpal.
Yeah, hello everyone. It's a pleasure to present to you. My name is Raj Lakhanpal, and I am one of the founders of SpectraMedics. Just briefly about us, we are 9 years old as a company where we've got 80 employees, growing, and we have been in business, we exist in business to help our clients transition to value-based care. And the platform uses three core competencies, very strong competency in data aggregation and warehousing, normalization. We have our own enterprise master patient index and warehousing. Second is measures, calculation, and reporting. And third is population health and financial risk modeling. You know, Sri had mentioned to me very clearly, look, Raj, this needs to be a non-promotional webinar. I have a couple of slides just to demonstrate our credibility. In addition to my duties at SpectraMedics, I also serve on the HIMSS, National HIMSS BI and Intelligence Committee, as well as on the National Governance Board of MITA. MITA is Medicaid Information Technology Architecture. Our clients, so most important about this is that we learn from our clients. We learn from our clients. Some of them have very, very smart people, many much smarter than me. So we learn from them, we understand what their needs are, and then provide. And within the value-based care domain, excuse me, our solutions are for Medicare as in Mips, in Medicaid as in New York District. We have the lion's share, or not the lion's share, we have a significant market share of District New York. So learn a lot from them and have really evolved in our understanding of the different data sets needed to impact change Medicaid populations. And then also commercial health plans, which is clinically integrated networks, doing a lot of work with Mount Sinai around CIN, and some work with University of Rochester Medical Center around CINs as well. And that is the pay-for-performance programs for health plans, commercial health. Integrated with a number of HIEs, and all our measures are certified by the ONC.
Raj, the screen's not moving for some reason. There's a technical issue, I think.
Sorry, Sri, didn't realize that. So, okay. Sri, this is yours now?
Yeah, so thanks, folks, for joining the call. This is Sri Bharadwaj, Director of Information Services and CISO for UC Irvine Health. I'm very much part of the Southern California HIMSS chapter, past president of the chapter, and the chapter has done a lot of human work for our community in Southern California. One of the largest chapters in the nation and won the large chapter award for many years, thanks to our very, very participative member population and just in broad sense, our healthcare community. We have a phenomenal program of events that we put together every year. I think this is another great event that folks can understand how we do what we do, and it's all focused on ability to serve our community and our membership. I am part of the National MACRA Advisory Council with a host of other folks, as you see on the screen. Dr. Karen Bell, David Mintz, Drex Ford, these names are what I would call household names in healthcare IT who shaped our public policy efforts around MACRA and moved stuff around to help deliver what we need to deliver for our patients. The rest of the folks, as you see, are all coming from various areas in similar roles as mine and many people in the industry who helped with shaping how we deliver to the policy that is prescribed at the federal level. Next slide. I'll give you a bit of idea about UC Irvine Health. UC Irvine Health is a trauma center in Orange County, 450-bed hospital with a lot of ambulatory and other surgical specialties. We also have a very well-known School of Medicine, along with now very well endowed. We just received a $200 million grant for a integrated health medicine initiative that is from the Samweli family, and that's going to take healthcare from Irvine and beyond into great depth, great lengths and depths, because we believe that research, discovery, and service back to our patients is something that we would like to do. And UC Irvine Health has done that for many, many years as part of the University of California system. Next slide. So let's talk about MACRA and, what is MACRA all about and what is Mips all about? I was at a conference a few weeks ago, and we were talking about the extent of how MACRA can actually change the value-based healthcare system if it's used appropriately, not to the letter of the law, but to the reason why law was put in place in the beginning. So just to give you an idea how it works out, it applies to individual EPs and groups of EPs or virtual groups. Just to give you an idea of where it's applicable. For the year 2019-2020, very similar to the PQRS EP discussion, and changing it slightly as we go through the advanced APM model. So 2019-2020, physicians, PAs, NPs, CRNs. So that's where the applicability is. And then from 2021, they should be significantly participating in the advanced APMs. newly enrolled in Medicare, and you're looking at the volume threshold that becomes applicable, because you want to make sure the types of EPs are expanded to get that eligibility out. For 2017 year, out of the 1.3 million Part B clinicians, CMS looks at about 600,000 that are going to be MIPS eligible, and some 100,000 odd on the APM clinicians. So that thing is going to grow, but this is just where we are starting. Next slide. So let's talk about MIPS. As you can see, and we will send you the slides after this call. As you can see, what is MIPS and what is advanced APMs kind of give you an idea. Beyond 2019, you're going to get, either a plus or a minus on the 4% side as it grows to a 9% by 2022 in terms of reimbursement and adjustments. So that's where I think value-based care really hits home. When it starts impacting your payments on an ongoing basis. And as the numbers grow up, the requirements associated with it also change and delivers that value-based healthcare to our community at large. That is the goal, that is the intent, and that's where we will see how a solution that will help through this process not just looks at a quality reporting metric or a measure or how are we performing, but actually significantly make changes in how healthcare is offered across our spectrum. And we'll talk about the triple aim as well as we move together on these slides. Next slide. Nathan, next slide.
We've advanced this, Ray.
I don't see it. Oh, I see it now. Thank you. So let's look at the 4 areas. In quality, it replaces the PQRS, and we've been asking for some sort of a standard around how do we bring it all together and make it work. And we talked about it at length. I was in a Philly roundtable. We talked about this at length. How do we replace PQRS in a way that it makes meaningful sense? How we look at clinical improvement activities? What are the things that we need to do around clinical improvement activities? How do we advance care information? It's very important because we struggle with meaningful use. Whether we like it or not, we struggle with meaningful use as an industry. And at some point in time, I'm glad that folks realize that meaningful use is not really meaningful, right? When it doesn't deliver the value you need, it become meaningful use once starts becoming check the box. Just like we used to think about HIPAA, the same thing happens. So I think the advancing care information measures really changes the way we look at meaningful use. And of course, the cost aspect is another big deal there. And just looking at the changes that are coming or at least being proposed around the 60% on the quality side, and of course they realize that cost they can't do as much on the modifier side, though we got it back to 0. We'll see what happens in 2019. But these are some of the changes that is being incorporated from a MIPS performance categories. So we'll work through this process. So for 2017, 60% quality, 15% clinical improvement, and 28% advanced care, which is similar to meaningful use. So that gives you a number. And as we grow, this will change and make it more, hopefully, helpful for the healthcare industry as a whole. Next slide. Let's talk about the advanced APM models for a minute. We discussed MIPS. Let's talk about APMs. This is where you have really the risk-based component built into this. You have the shared savings program, the multiple tracks we've had now, 3 tracks now, and specifically now we are trying to target specialties. The oncology care model gives you the two-sided risk around delivering oncology care. And we know that, the oncology practice as a whole is such a big industry that on its own has to be managed in a different form because the costs incurred in that specific disease treatment process is fairly large. So that is something that we realize we need to do. Then you look at the joint replacement aspect of it, and that really needs to make sure we've got those. So you look at where the high DRGs are and what we need to do there. These are the standard APM models we bring into place. What does it really do? It makes sure that not just the person who is performing a single episode is addressing the measure, but everybody associated with that specific patient is addressing the measure. That's when we really hit home in terms of delivering for all of the providers engaged in that treatment of that specific patient. How are they taking care of that patient? That's where really the risk comes into play. Next slide. Nathan?
Yep, thanks, Sri. We're going to pause a minute and do our first survey. How is your organization implementing or planning to implement Mips? I'm going to launch the poll and give everyone about 45 seconds to answer. Okay, thanks everyone for participating. I'm going to close the poll and share the results. So 50% who responded said utilizing their EHR, 29% utilizing an outside resource, and 21% for no strategy yet. And no one responded for the GPro reporting via CMS. Thanks, everyone. I'm going to close this, and we will continue.
So, as I was talking to you folks about MACRA and Mips and APMs, ultimately, what are we trying to drive towards? We're trying to drive towards these three. We need to improve the level of quality. We know United States is, does not deliver the best quality for the price you pay. It's a very well-known fact. I mean, you look at WHO information or information is published by ONC, CMS, and anywhere else, it'll tell you that, United States is a fairly high price for low value care. So we expect our quality to improve, number one. Number two, cost management, right? You got to manage cost. You got to deliver to what we need to get done to understand how this is going to make it work from a cost perspective. So you have to start aggregating costs, working through, figuring out how to make it work. And then improving patient and physician engagement. It's probably more important to have that collaborative decision-making process in patient care. We are going from what we would call the paternalistic management of medicine to a collaborative, value-driven healthcare environment where the patient takes some sort of responsibility. I couldn't say all of it. Patient takes some responsibility to make sure he is part of his care program, his care plan, his care process. Now, it's not just the patient, of course, it's the care team, which could include, moms, daughters, sons, whoever, immediate family and extended family who take care of the patient as well. So that's important to that. And of course, the physicians. No, it's not just the physician, the PCP who is taking care of the patient, but the PCP along with this extended consulting team, as well as the care team, the nurses, the the CRNs, the anesthesiologists, you name it, all of the people who provide care to that patient. So we're talking about the fact that because we believe that MACRA is definitely a stepping stone to comprehensive value-based care, we think we'll hit these three things for sure. Next slide. So why would we look at this way? And why would we consider not just reporting to MACRA as a chore, but actually as a way to improve care, as a way to help through, the triple aim, right? Access to care, quality of care, patient engagement. How do we do that? What do we do here? And how can we take these measures? You have to report on them anyways, but reporting on them is one thing, and to make sure you get the cost value down, the cost curve down is one thing. But really, how would you do each of these, improving quality of care, improving access to care, and getting patient engagement? That is probably going to be the more important factor we have to hit, because, typically we've done things for the sake of reporting, but how do we look at, a level of capability across the continuum of the patient to make sure the patient's care improves, not just cost, but the patient care improves. So we improve that, we take the measures to heart and deliver that. Next slide. So let's look at quality of care, right? We are looking at, the measures. We look at the measures that we report. How do we take those measures, and how do we identify what we need to do to help improve care from a quality perspective, right? How do we improve healthcare quality? Number one, you identify gaps. You identify the measures, you got a baseline. You look at where you are, you look at what you got to achieve, and then you look at what are the gaps that you need to look at, and how do you build those gaps into your EMR, number one. Number two, how do you identify gaps in care? I mean, is the care comprehensive enough? Is the something that is very unique is that we don't worry about normally in the healthcare system what happens if the patient goes back home and there's nobody able to to feed him the right type of food or mechanism that he needs to get to in order to become better. He goes back to his old ways, and he's, within a matter of 15 days, lands back in the ER. You have then a readmission issue. So that is something that you can identify and start working through from a social environment, economic factors. And that's where you identify various aspects of you can provide care. That's a gap that you may not have identified today just purely based on measures. But if you look at measures over a period of time using patterns and trends, you'd be able to see areas where organizations can actually help the patients through a specific chronic set of population to work that process. Some people call it population health management, not truly so, but definitely that's an angle that you would pursue. Next slide. Access to care. This is probably one of the most critical aspects that we need to consider. Very few hospitals and clinics have the ability to provide their patients with, a consult within a short span of time. When you're looking at the patient population, you've done the trending, you identify patterns. Now okay, he needs to see a cardiologist within 2 days. Can we get an appointment for the cardiologist within 2 days? That's what we believe that the measure tells us. But then if you build that into your EMR and say, get a best practice alert or some sort of a notification mechanism to say, hey, we see this patient having these chronic diseases and these chronic symptoms. Maybe this is what we have seen with, a host of about 5,000 similar patients. And we found that, if he had a cardiology consult with, regular monitoring of his heartbeat or his blood pressure, we've seen changes in healthcare. So if we look at that and help with that access to care by prioritizing and these patients and setting actually target appointments for them before they leave the clinic, that will be the best way to help through this process by looking at the holistic form of value-based care. Next slide. Patient engagement. The patient is going home, but the patient is not going home and leaving his healthcare behind. He takes his healthcare with him. Now, there are ways to help the patient become better, because at the end of the day, you are accountable for the patient, whether you like it or not. Instead of him going to go and see another physician, another PCP, who is not part of your network, who's not part of your shared services model, not part of your ACO, you need to help keep him better. So we want to make sure that you give him a device or some sort of a monitoring capability that you know for sure needs the level of monitoring based on gaps in care, that based on trends and measures that you've already seen. That's a huge value add. Forget MACRA, forget Mips. Yes, there is a cost aspect. Yes, there is a value aspect. We get it. But just purely based on where we are, how do we take that patient and help him identify what are the vulnerabilities that he's going to get to if we don't take care of him? So give him some monitoring capability, maybe a frequent checkup with his PCP that is already connected with you, maybe a weekly checkup with his cardiology doc if we require. There are things that we can do, and based on metrics, you can figure this out. One of the things that we found very effective was a follow-up after admission for behavioral health, where you can see that once we've identified a pattern for these types of patients, a 7-day follow-up, a 30-day follow-up really helps benefit the patient. Next slide.
So this is where I have a few slides now. So this is how do you justify an investment in MACRA and Mips? So obviously it's a significant investment, and what we have found is that our clients are saying, we're building this infrastructure to collect the data. We're building this infrastructure to normalize the data, to populate an enterprise data warehouse. Let us leverage this data for multiple programs. Let us leverage this data across the continuum, not only for MACRA and Mips, but also for clinically integrated networks where we have pay-for-performance programs or risk-bearing programs with health plans, where we are also taking care of Medicaid patients, maybe DISREP, maybe some other pay-for-performance programs with Medicaid HMOs. So that's what we're finding, at least here on the East Coast. And as an example, we're also working with LA Care. We're working with their TCPI program there. So MACRA, CIN, so across the continuum for various ACO programs too, and other pay-for-performance CPC Plus, but other pay-for-bundled payments as well. So the infrastructure you're building can be leveraged throughout other various commercial programs as well. And I have missed a slide. Okay. So also along with that is a component of predictive modeling, where you can enable physicians to make better choices, which patient is at high risk for readmissions, to bring them to refer them or to discharge them to the right places, and also care and cost to deliver improved quality at an optimized cost. Some of the data and technology challenges. Now let me focus at Mips, because that's what the webinar was about, Mips and MACRA. So data obviously resides in multiple silos. You have data within the EHR, you have data within the clinical systems, you have data within claims, billing systems, survey data. So aggregating that data is a challenge. Now the other challenges we found is that if you have multiple TINs, the TINs or multiple practices, the practices might have different EHRs. So even aggregating that data becomes a challenge. Inpatient, outpatient may have separate EMRs as well. And then some practices may not have an EMR, where then manual chart abstraction may need to be. And so combining different sources of data is a challenge. An EMPI, Enterprise Master Patient Index, plays a big role there, can be very helpful. And then We've also found that to effectively report for Mips, there may be a need, or there is a need to take in billing data and then also take clinical data to effectively report, unless you're using Mips. So here are the different data collection methods. Collecting data from the EMR using CCDAs. Collecting data from intelligent chart abstraction is taking in billing data to calculate the denominators. A lot of the times, many hospitals or health systems have G codes already within the billing files, so that becomes easier. G codes are CPT2 codes. If they are not there, and we're finding that especially with larger health systems, that they're saying our clinicians do not enter the G codes, then getting clinical data, either as a CCDA or as a custom data feed, may be very helpful in the ability to calculate the numerators. For smaller health systems, for physician practices that may or may not have an EMR, chart abstraction and using web forms to calculate or to provide the numerators is another option. And then with our framework, we can calculate the measures, and the focus is on improving performance. The focus should not be on reporting. That was the focus of the yesteryears. Now the focus is, most of our clients ask for a monthly update so that they can look at how at a provider level they're performing, so that they can optimize their performance. They can have comparative analysis and help their physicians or their providers, their clinicians, improve their performance. And something I'd like to bring up again and again is that Mips is a starting point. Mips and MACRA are what the federal mandate is. But along with that, please don't think of other programs that may be there. For example, again, the CIN, the TCI program, or other programs that you may be doing, since you're already investing in this infrastructure.
Okay, thank you, Raj and Sri. Pause for a second poll here. What is your biggest challenge with the upcoming transition to MACRA? Give everyone about 45 seconds. Okay, thank you, everyone. Sharing the results. So 43% who answered said collecting the data necessary to measure and report. That was the biggest choice, followed by 29% for both identifying measures, activities, reflecting best performance, and ability to compare. Back to Raj.
So a few slides about the solutions that are. So here is what number of vendors do that we also do is provide a Mips readiness assessment. As number of you. So the bigger challenges, as I saw the poll, were around data aggregation and ability to identify measures. So that's what the readiness assessment is really focused on. We first work with, the optimal approach is to first work with the client and look at the measures that they've selected in the past for PQRS or other activities, see if those measures made it to the Mips list. Most of them have, and if possible, see how they performed. But also we take a sample data set for about a quarter, and run it through our measures engine to see how they're performing. That also gives us an opportunity to understand the data gaps and where the data could reside for those measures. Sometimes we find that the workflows are still not developed in their native EMR systems to be able to collect data on certain measures. So then either we ask our clients to change the workflows or select different measures. So that's the goal of the readiness consultation, and then the goal is to finalize measures and reporting methodology. Again, talking of a holistic value-based program, and especially touching on issues that Sri had highlighted. So the key components we believe is an enterprise data warehouse. Obviously, that takes in the data, normalizes, harmonizes the data, if needed, applies an EMPI, and then populates an EDW. Then measures, calculation, and reporting for Mips. Reporting is a big part, whether it's through a registry, whether it's a QCDR, or it's ECQM reporting. With ECQM, data aggregation becomes easier for us because that's QRDA wants. And then I think very importantly, as the industry is evolving, you're all moving from reporting to performance improvement because, as Sri had pointed out, the incentives and the disincentives are very huge. So a 4% incentive and a 4% disincentive or a penalty amounts to an 8% delta. A 9% incentive and a 9% penalty amounts to an 18% delta. So performance improvement is very important, identifying gaps in measures on a monthly basis, if not more frequently. What we've heard is more than that becomes noise to the busy clinicians, but every month, identifying gaps in measures, identifying gaps in care, and providing that to the clinicians so that they can take effective action it has become critical. And then we talked about readmissions and behavioral health issues, predictive modeling as well. And I think Sri had touched on population health too. So all of that ends up being population health. And some of the components of population health and risk stratification, utilization analytics, also important for MACRA. So if you're in an ACO setting or you're in some kind of MSSP, track 2 or 3, or even cancer care, all of this, the risk stratification and utilization analytics and the scorecards become very important. So what do we recommend that you should, when you embark on this journey? If you've embarked already, great, kudos to you. If you have not, or you're looking, I think, at least again, from my point of view and from our point of view as a company, that you should align this across various programs. It should not be about Mips and MACRA. It should be about transition to value-based care, which is risk-based models. And I think California is much farther ahead than the East Coast for that matter. So all of these programs that are highlighted here, data aggregation normalization is key because that foundation allows you to do multiple things. If your data is credible and the source of truth, that allows you to do different kinds of analytics. The measures validation should be done by external bodies, whether it's the ONC, it's the NCQA, organizations that are qualified registries, and QCDRs are at a better point at that point in time, are a better fit. And then performance improvement, I've talked about that. And then, cost is not a measure this year or next year, but suddenly it'll become a big component, and we should be all prepared for that because that will play a big role in how the whole incentives are given for MACRA and for Mips too, and population health capability. Now, Nathan, do you want to address the questions that we may have received?
Yep. Thank you again, Raj and Sri. We've had a few questions come in, so I know we're kind of running short on time here, but if you have any questions and we don't get to answer them today, please feel free to reach out directly. Joining us here to help answer questions is Christine Wismer. She's a business analyst here at Spectrumetics and is particularly focused on macro and Mips. First question I see, where is CMS proposing to set the Mips performance threshold for 2018?
Yes, so just to step back a moment, what the performance threshold is that for each performance year in Mips, CMS will determine what a threshold will be that if a particular clinician earns that Mips score, that they will get a zero or neutral payment adjustment to their Medicare reimbursement in the payment year. So for this particular performance year in 2017, the threshold is set at 3. And so if you essentially score a 3, you're going to get a neutral payment adjustment in payment year 2019. For 2018, what's in the proposed rule is that if you achieve a performance threshold, or if your MIPS score essentially is a 15, that's where the performance threshold is set, such that if you achieve a 15, then you'll get a neutral or a zero payment adjustment for your payment year, which would be in 2020. And of course, the way the MIPS scoring works is anything above the performance threshold in terms of a score. So if you were to get greater than 15 in 2018, you would get a bump up to your Medicare reimbursement in the payment year, and anything lower than the performance threshold, so anything lower than the score of 15, say, for the performance year of 2018, you would essentially earn a negative payment adjustment. In terms of the types of activities that what the difference would be in terms of, say, for this year as compared to performance year 2018. This year, as many of your primary would be aware of, that for this year, with the pick the pace and the performance threshold being set at 3, really all you have to do is submit one quality measure or the base ACI measures or an improvement activity, and you can essentially score that 3 points or above and get a neutral payment adjustment. For 2018, essentially, that 15 points would make the clinician have to do a little more. So, for example, assuming that you were going to, say, submit 5 quality measures and they had a benchmark and you were just going to get the minimum score, that could yield you the 15 points. So, essentially, CMS is saying that in 2018, you're going to have to do a little more in order to just get that neutral payment adjustment. I hope that answers the question.
Thank you. So another question here. What will be the performance reporting period for 2018 for the quality performance category of Mips?
Yes. Yeah. So CMS is going to, is looking, again, this is in the proposed rule, to have the full calendar year be the performance period for quality. For the other 2 performance categories in play for 2018, which are the advancing care information performance category and the improvement activity performance category, CMS is looking to retain the 90-day minimum reporting category for those particular measures. And as was mentioned before in this webinar, right now they're proposing that cost still be weighted 0 for the 2018 performance year.
Okay. So that we're running out of time here, so that's going to be everything that we answered today. Dr. Lockenpal or Sri, if you have any final thoughts, please feel free to share them.
I think this has been a great event for us. We hope our members really appreciated our ability to shed some light, not everything obviously, shed some light on it. And feel free to contact us and we can loop you back with additional information if you need it. The one thing I ask all of our members is to not look at MACRA and MIPS reporting chore, but actually as a ways and means to improve care quality, access to care, and better patient engagement.
Great. Thank you, everyone. Appreciate your time.
Okay, thanks everyone. Thanks again. Thanks Sri. Thanks Raj. And again, if you have any questions, please feel free to reach out to us directly. And we hope everyone has a great rest of their day. Take care.
Thank you.